Now, just a few points about what we're talking about. The ICL, the Implantable Contact Lens, is a lens which is in the posterior chamber. We got CE mark in '97 and FDA approval in 2005. We are present in more than 60 countries, and by today we have about 185,000 lenses implanted. And we are on a growth curve. We grow every year in the rate of about 35%. We are very proud for that, and we see actually quite nice future for that technology. We produce our lenses in Switzerland. That's where my home is as well. And you see this little picture on the top with the Eiger. We are not far away from there. This is how the lens looks like. It's a very thin lens. It is in the center, the optic. It's only up to 15 microns thin. And you see on the left end, the haptic part is up to 100 micron only thick. Now, the lens is basically a customized lens which is correcting both spheric and with the toric version the astigmatism as well. In principle, it's customized for the individual eye, for the patient. Now, we do have a certain allowance to rotate, basically to adjust the positioning of the lens, as you can see in the image, where the alignment is shown in the horizontal and the lens is slightly rotated to optimize the position of the cylinder. Now, what's the prescription range? Well, it's basically whatever you can imagine. I almost would want to put it like that. We cover the whole range of myopia, starting from -5 to -18. We cover the whole range of hyperopia, from +0.5 to +10, and we do cover all myopic and hyperopic options with a cylinder on top of it in the hyperopic range up to 6, overall cylinder correction up to 6 diopters. Now, quickly on the label indications, well, typically the patient is between 21 and 45 years old. It needs to have a stable refraction. The anterior chamber depth is 2.8 millimeters and larger. Obviously no previous ocular pathology is required. The pre-op evaluation is pretty straightforward. You would be mainly looking at the eye parameters, and I'm just picking the 4 relevant ones to decide on the optimal length and lens. You would measure ACD, anterior chamber depth. You would measure the white-to-white distance. You would measure the corneal thickness, and you would measure the K values. With those data and our software, which every trained surgeon has access to, you basically make the calculation and get the lens which is required for the individual patient. Some highlights about the pre-op assessment. Yes, you should do both manifest and cycloplegic refractions. Contact lens wearers, this is very important. You have to make sure that rigid contact lenses are taken off 3 weeks before the exam is made, otherwise you're going to have refractive surprise. The 3 to 5 days, that's what we recommend for a soft contact lens wearer. Now, this is an interesting image, I believe, because it shows you the effective optical zone of the lens. This is the crystalline lens, and here between crystalline lens and the iris, this is where the ICL is sitting. Now, the fact that the iris is, the ICL, the implantable contact lens, is so close to the crystalline lens, it gives you a larger optical effect on the retina than the real optical size is indicated. So 5.5, which is the optical diameter of the ICL, translates into a 7.3 millimeter corneal plane equivalent. ACD, well, the ACD to be used for the ICL calculator is from the endothelium. Sometimes this is confusing with the epithelium. No, it must be from the endothelium. And so the corneal thickness is never included in those numbers. ACD may alter the post-op expected refraction, yes, that's clear, and the ACD may alter the suggested ICL lengths to be implanted. This is an important point. So we do not look only after the refraction and the wide-to-wide lengths. We also have adjusted the nomogram for the lens selection based on the size of the eye, which is determined through the ACD measurement. Now this is one way how you can measure the wide-to-wide with the caliper. Some people do it with the orb scan. Some people do it with the IOL master. Various technologies are out there to determine the lens length. Here you can see the steps for the implantation. Basically what you would start off with doing is you do 2 openings, either with a YAG laser. You see the 2 openings here to guarantee the flow from the posterior to the anterior chamber. Or you do 1 opening with a surgical PI, which is typically a little bit larger. So dilation of the pupil, obviously loading the lens, and you can see here the lens, how it's loaded in the cartridge and wonderfully aligned. Then you do an opening in the eye, the main incision. You do 2 side openings. Some surgeons will do only 1. Inject some viscoelastic, inject the lens, and let the lens position in its right position. Remove the viscoelastic and close the pupil. That's typically a very straightforward surgery. Now, I brought you a little video, and this is a video with a surgeon from Belgium, Dr. Eric Mertens. You see the preparation.
For toric ICL surgery, only few instruments are needed.
Of the instruments.
The first step is to fill the cartridge with methylcellulose.
And that's a
Be
cartridge
sure
which we
not to
provide.
overfill the open end of the cartridge. This space is filled with a few drops of BSS.
So this is just a material to lubricate
Then
the cartridge
container is
so the lens can glide through.
And with a soft plunger, the ICL is removed from the bottle.
Now here you can see the lens. And it's a tiny little lens.
The ICL is then positioned in the open end of the cartridge, and with the Vukic forceps, the lens is placed into the cartridge, pushed forward and tucked in. Under the microscope, the ICL can be pulled into the tip of the cartridge with a bended forceps. In this way, the ICL is nicely stretched in the tip and can be delivered during surgery without problems.
So you bring it to the forefront of the cartridge and then you dock it into the injector.
Before the patient is placed on the operation table, the horizontal axis is marked at a slit lamp and 2 dots are placed at the limbus. The markings at the limbus indicate the horizontal axis. This axis is highlighted with a marker which is firmly pressed onto the cornea to create epithelial indentations. To create a watertight 3-step incision, first a 600 micron groove is performed. A single paracentesis is placed nearby the location of the distal haptics. Preservative-free lidocaine is injected into the anterior chamber, followed by methylcellulose. Make sure that the strands of the methylcellulose are still visible, otherwise there is a risk of overfilling the chamber. The main incision is performed with a 2.65 mm double bevel knife. The cartridge is then placed firmly against the incision and the ICL is injected. Wait to remove the cartridge until the distal part of the ICL is unfolded. To push the lens downwards, a little bit of methylcellulose is placed on top of the intraocular lens. With the toothed forceps and through the main incision, the proximal haptics are placed behind the iris. Make sure not to touch the optic part of the ICL because of the risk of touching the crystalline lens. Through the paracentesis, the distal haptics are then placed under the iris. Do this very gently and try not to touch iris or crystalline lens. At the end of surgery, the diamond-shaped markings on the toric ICL are aligned with the epithelial indentations which indicate the horizontal axis. In this way, the astigmatic correction in the optic part of the lens is aligned with the cylindrical error of the eye.
And you can see this is straightforward. He does bilateral surgery, so the patient walks in and 15 minutes later he walks out. And I just want to share with you a couple of data which Professor Shimizu had presented not so long ago. So he looks at basically what is the quality of vision post-LASIK versus post-toric ICL. And he has two groups, 20 eyes in the toric ICL group, 49 eyes in the wavefront guided group. And when you look at the average diopter correction, the toric is obviously higher, minus 9.8, versus wavefront guided is minus 7.8. Here you see the correction from minus, what I just said, minus 10.57 is corrected post 3 months to minus 0.2, and in the LASIK group to minus 0.35. When we look at the refractive cylinder outcome, it is corrected from 2.47 in the toric ICL group to 0.53 and 1.24 to 0.47 in the wavefront guided group. That I think looks all great. Now safety index. Toric ICL has a safety index of 1.24. The wavefront guided is at about 1.98. Now efficacy index, this is the highest standard you can look at. This is where your pre-op best corrected is corrected with your post-op uncorrected. And this is a stunning result. It's basically 0.94, an efficacy index of 0.94 versus 0.79 for the wavefront guided laser. So this means you basically can tell your patient that your pre-op best corrected result is always achieved with your post-op uncorrected. Predictability, here the data behind the image. The ICL, there is not much to make wrong if your pre-op assessment is right. You just put in a lens. And even the eye can move to the left or to the right. Ocular higher order aberrations. Now that's another point which actually Shimizu tries to point out. When you have only an incision of below 3 millimeters, and with Merton's video it was only 2.65, there is not much correction you do to the refraction of the eye. It's very clear, so you basically you don't change the higher order aberration. That's why it's non-significant, the change, whereas when you do a cut opening, then for sure the higher order aberration is worsened. And in consequence to that, contrast sensitivity on the left side for the toric ICL, it goes up. The red line is 3 months post-op, contrast sensitivity is going up, whereas with the wavefront guided, it's going down, and this is, I think, obvious. Now, here's just a slide from a study we did in the US with toric ICL, FDA study, and it shows you an extremely high rate of patient satisfaction, 98%, 1 year post-op. This is how the lens sits in the eye with a slit lamp view. You see the lens nicely vaulted forward. That's the crystalline lens, that's your cornea, and this is what's important. Keep the distance between the ICL and the crystalline lens. In summary, Superior quality of vision, very important argument for the ICL. Reversibility, if you ever have to take out, well, correct your refraction, take the lens out. It's absolutely possible. No change in actual lens readings, so if you do the correction now and 20 years later you have to go through a cataract operation, your K readings have not been changed, so your prediction of your cataract lens is correct. Before closing, I just want to make a little recruitment advertisement on our behalf. Our marketing people said, this is a great group of optometrists, etc., and we are continuously growing. We always look for optometrists, and if there's anybody who's interested in joining STAR, please don't hesitate, give us a call, and with that, thank you.